Dear students, myself Deepa speaking. Today we will discuss about jaundice. We already studied the metabolism of bilirubin, and this bilirubin is the breakdown product of hemoglobin, the catabolic product of hemoglobin, and jaundice, the accumulation of yellow pigment, the skin and the other tissues. The color of bilirubin is yellow, and different types of jaundice already studied, and pre-hepatic, hepatic, and post-hepatic jaundice. Pre-hepatic means before liver cells, hepatic means in liver cells, and post-hepatic after any complication after liver cells. That is post-hepatic. Post-hepatic jaundice is otherwise called the obstructive jaundice. In hemolytic jaundice, unconjugated bilirubin level increases in blood. In hepatic jaundice, both the conjugated and unconjugated bilirubin level increases, and in post-hepatic jaundice, conjugated bilirubin level increases in blood. Bilirubin metabolism, including bilirubin formation, transport of bilirubin in plasma, hepatic bilirubin transport. Hepatic bilirubin transport including the hepatic uptake, conjugation, biliary excretion, and enterohepatic circulation. Bilirubin formation, we already discussed in the previous classes. The dissection of RBC after 120 days, it is converted to heme and globin. Globin is utilized for the body, and the heme, the ring is broken, and the breakdown of the heme ring to form the firstly formed compound is bilirubin. Bilirubin is converted to bilirubin. The firstly formed bilirubin is called the unconjugated bilirubin. This unconjugated bilirubin combines with the albumin and transported form in the plasma, and this bilirubin albumin complex, and then bilirubin enters the hepatic cell. The unconjugated bilirubin is converted to conjugated bilirubin by conjugation. With the help of the enzyme bilirubin diglucuronidase, and then the conjugated bilirubin enters into the small intestine via bile duct, and the bilirubin gives yellow color to bile, and in the intestine this conjugated bilirubin is again converted to unconjugated bilirubin, and by the action of the bacteria it is converted to urobilinogen and stercobilinogen. Urobilinogen is excreted through urine, and stercobilinogen is excreted through feces, and the small part of bilirubin is reabsorbed into the hepatic cell via enterohepatic circulation. This slide discusses about the bilirubin formation. Bilirubin formation, the 70% or the chief bilirubin formation, 70% of bilirubin formation, bilirubin is getting from destruction of RBCs after 120 days. That is the senescent RBCs. It is converted to the iron, hemoglobin, and the globin. The hemoglobin, the globin part is utilized to the body, and then the heme is converted to biliverdin, and biliverdin is converted to bilirubin. Heme is converted to biliverdin with the help of the enzyme oxidase, and the biliverdin is converted to bilirubin with the help of the enzyme bilirubin reductase. And the 20% of bilirubin is converted to 20% of bilirubin is getting from the hepatic hemoprotein. In hepatic hemoprotein, that means it is a non-hemoglobin heme and a non-hemoglobin hemoprotein. And 1 to 5% of bilirubin is getting from the premature destruction of newly formed RBCs. And the major form of bilirubin is getting from the destruction of mature RBCs. And some part, the 20% is getting from the hepatic hemoprotein, and the 1 to 5% is getting from the premature destruction of newly formed RBC. The transport of bilirubin in plasma. Bilirubin, that means unconjugated bilirubin. It is the firstly formed bilirubin combined with the albumin to form bilirubin, unconjugated bilirubin albumin complex. In a high affinity binding site, the molar ratio of bilirubin and albumin is 2:1, and in the low affinity binding site, the molar ratio of bilirubin and albumin is less than 2:1. Pathophysiology classification of jaundice. Hemolytic jaundice, hepatic jaundice, obstructive jaundice. Obstructive jaundice otherwise called the post-hepatic jaundice or cholestasis, and a congenital jaundice. Hemolytic jaundice, it is otherwise called the pre-hepatic jaundice, hepatic jaundice, obstructive jaundice, cholestasis or post-hepatic jaundice, and the congenital jaundice. The underlying cause for hemolytic jaundice is hemolysis. Hemolysis may be extrinsic or intrinsic. Extrinsic hemolysis means developed by several methods. The spleen traps and destroys healthy red blood cells, or an autoimmune reaction occurs. It can also flow from red blood cell destruction due to infection, tumors, autoimmune disorder, medication side effects, leukemia, lymphoma. Then intrinsic hemolytic. When red blood cells produced by our body don't function properly, this condition is often inherited, such as in people with sickle cell anemia or thalassemia, who have abnormal hemoglobin. Other times, an inherited metabolic abnormality can lead to this condition, such as G6PD G6PD deficiency, or red blood cell membrane instability, such as hereditary cirrhosis. Anyone of any age can develop hemolytic anemia. Underlying causes of extrinsic hemolytic anemia include enlarged spleen, infectious hepatitis, Epstein-Barr virus, typhoid fever, E. coli toxin, leukemia, lymphoma, tumors. Then systemic lupus erythematosus is an autoimmune disorder. Then HELLP syndrome. HELLP syndrome is capital letter HELLP, HELLP syndrome. In this, the H, hemolysis. ELL, that is elevated liver enzymes and a low platelet count. Some medications cause hemolytic anemia. For example, acetaminophen, some antibiotics, cephalaxin, penicillin, ampicillin, etc. Then flupromycin, ibuprofen, interferon alpha, quinidine, rifampicin. Then non-immune hemolytic anemia. Non-immune hemolytic anemia is a rare acquired syndrome. Example, paroxysmal nocturnal hemoglobinuria. In this condition, it is a rare chronic debilitating disorder that most frequently present in early childhood. 50% death affected individuals. Death rate is 50% due to thrombotic complications. Symptoms of hemolytic jaundice. Symptoms: weakness, dark urine, anemia, visceral and splenomegaly. The lab findings: unconjugated bilirubin level increases without bilirubin urea. without bilirubinuria, but urine urobilinogen increases. In blood, unconjugated bilirubin level increases, and in urine urobilinogen level increases. And also hemolytic anemia and hemoglobinuria. In acute intravascular hemolysis, sometimes the hemoglobinuria found and reticulocyte count increases. The most important lab diagnosis is the unconjugated bilirubin level in blood increases with urine urobilinogen. The clinical diagnosis criteria for hemolytic jaundice. The normal serum bilirubin level is 0.2 to 0.8 mg per deciliter. Some specifications less than 1 mg per deciliter. And the aspartate transaminase, the normal range is less than 35 international units per liter. Alkaline phosphatase, the normal level 44 to 147 international units per liter. And the gamma glutamate transferase, EGT, gamma glutamate transferase, the normal range is 15 to 40 IU per liter. And the albumin in a gram per deciliter, 3.5 to 5.5 gram per deciliter. And the reticulocytes in percentage, normal range is less than 1. And the prothrombin time in seconds, normal range is 13 to 15 seconds. Hemolytic jaundice, urinary changes. We are finding changes in urinary changes. It is bilirubin absent, but urobilinogen increased. In the fecal changes, cercobilinogen is normal. Obstructive jaundice, the pathogenesis is due to intra and extrahepatic obstruction of bile ducts. Intrahepatic jaundice, hepatitis, PBC, that is primary biliary cholangitis, and certain drugs. It is a primary biliary cholangitis. It is previously known as primary biliary cirrhosis. It is an autoimmune disease of the liver. Primary biliary cholangitis, PBC. Primary biliary cholangitis. It is an autoimmune disease of the liver. The complications: cirrhosis and hepatic failure. And extrahepatic biliary obstruction. Extrahepatic biliary obstruction due to stones or bladder stones, puncture, inflammation, tumor, ampulla of water. Tumor means mainly the tumor present in the head of the pancreas. Tumor present in the head of the pancreas. The etiology, reason for obstructive jaundice, intrahepatic liver cell damage or blockage of bile canal due to rupture chemical toxin, Dubin-Johnson syndrome, presence or pregnancy, hepatitis viral or chemical, infiltrate tumors, intrahepatic biliary hyperplasia or atresia, and a primary biliary cirrhosis. Drugs such as anabolic steroids and chlorpromazine are known to directly cause cholestasis. Then thiazide diuretic use may slightly increase the risk for developing gallstones, the most common cause for biliary obstruction. Then Dubin-Johnson syndrome, a rare autosomal disorder that causes an isolated increase of conjugated bilirubin in the serum. Rare autosomal disorder that causes an isolated increase of conjugated bilirubin in the serum. Classically, the condition causes a black liver due to deposition of a pigment similar to melanin. Then, atresia, that is absence or abnormal narrowing of an opening or passage in the body. Estrogen or pregnancy cause intrahepatic obstruction. cholestasis can arise estrogen containing OCPS. Most common liver disease in pregnancy. Intrahepatic or impaired bile formation in intrahepatic cholestasis. Intrahepatic cholestasis means impaired bile formation in the liver cells. The obstruction is the obstruction of bile flow by a bile duct. Cholestasis results in hepatic and systemic accumulation of cytotoxic bile acid. This induces liver damage accompanied by pruritus. Pruritus means itching. Accompanied by pruritus and indigestion, ultimately leading to biliary fibrosis and cirrhosis. Pruritus, that is the itchy skin, and the jaundice. So this may be idiopathic cholestatic jaundice of pregnancy. Pruritus gravidarum. Pruritus gravidarum means a severe itchiness of late pregnancy, and the idiopathic cholestatic jaundice of pregnancy are usually characterized by symptoms of generalized pruritus, mild anorexia, nausea, and occasional vomiting. In these conditions, serum levels of 5-nucleotidase, alkaline phosphatase, conjugated bilirubin, and bromosulfidylate retention occurs. Total elevation of bile acids and increase in folic acid. Etiology of obstructive jaundice. Extrahepatic obstruction, obstruction of bile duct due to compression, obstruction from tumor, congenital polydorsal cyst, extrahepatic biliary atresia, intraluminal gallstones, cirrhosis, postoperative or inflammatory obstruction. Compression obstruction from tumors, especially pancreatic cancer, when it occurs near the tube connecting the pancreas to the intestine. Pancreatic cancer when it occurs near the tube connecting the pancreas to the intestine. Swelling of implants near the bile duct and pancreatic cysts and other pancreatic duct obstructions such as scarring that also causes obstruction. Then another one type of carcinoma is hepatocellular carcinoma that may involve the biliary tract in several different ways, such as tumor thrombosis, hemobilia, then tumor compression and diffuse tumor infiltration. Bile duct thrombosis is one of the main causes for obstructive jaundice. Hepatocellular carcinoma caused by diffuse tumor infiltration of the liver parenchyma, then progressive liver failure, severe cirrhosis, or a combination of these factors. Hepatocellular carcinoma causes obstruction that is caused by diffuse tumor infiltration of the liver parenchyma and progressive liver failure, severe cirrhosis, or a combination of these factors. Then, atresia. Atresia is the absence or abnormal narrowing of an opening or passage in the bone. That also causes biliary obstruction. Atresia means the absence or abnormal narrowing of an opening or passage in the body. Then intraluminal gallstones. Intraluminal gallstones that causes cholestasis obstruction. These intraluminal gallstones are called the polylithiasis. These are intraluminal gallstones are solid calculus formed by precipitation of supersaturated bile composed of cholesterol monohydrate crystals. Intraluminal gallstones are solid calculi formed by precipitation of supersaturated bile composed of cholesterol monohydrate crystals, or sometimes it is called as black pigment of calcium bilirubinate. Here it is. Sometimes the gallstones are cholesterol monohydrate crystals, or sometimes it is calcium bilirubinate. This calcium bilirubinate is black in color. In United States, 80% of gallstones are from cholesterol monohydrate crystals. But in Asia, pigmented stone is predominant. In Asian countries, pigmented stone is predominant. The characteristic symptoms of gallstones are episodic attacks of severe pain in the right upper abdominal quadrant for at least 15 to 30 minutes with a radiation to the right back or shoulder. Cholestasis clinical features are pain, the pain due to gallbladder disease, then malignancy or a stretching of the liver capsule. Sometimes the fever due to ascending cholangitis. The fever occurs, pain, fever, then palpable under tender gallbladder, then enlarged liver. Liver usually swollen. The features are enlarged liver, the palpable gallbladder, then fever and severe pain. The general signs of cholestasis occur is xanthoma, then xanthelasma on the iris, finger clubbing, leaf pale, bulky, offensive skin, and dark orange urine. Xanthoma means a fatty growth developed underneath the skin. Xanthelasma is a sharply demarcated yellowish deposit of cholesterol underneath the skin. It usually occurs on or around the iris. Then, clubbing of the fingers. Club the fingers or clubbing of the fingers is an enlargement of the end of the finger accompanied by a downward sloping of the nail. Finger clubbing means is an enlargement of the end of the finger accompanied by a downward sloping of the nail. Then loose, pale, bulky, and then foul smelling stools. Then dark orange urine. That is dark orange urine with the presence of bilirubin in the urine. Obstructive jaundice lab findings. Serum conjugated bilirubin level increases. Fecal urobilinogen or stercobilinogen decreases in incomplete obstruction, and fecal urobilinogen or stercobilinogen absent in complete obstruction. Urobilinogen urea is absent. That means urinary urobilinogen is absent in complete obstruction of jaundice. And bilirubin urea, that means the bile pigment. Bilirubin level is increases in urine, and alkaline phosphatase level drastically or highly elevated in obstructive jaundice, and also cholesterol level increases in obstructive jaundice. Once again, the lab findings: serum bilirubin, serum conjugated bilirubin increases, then blood alkaline phosphatase, blood serum or plasma alkaline phosphatase level drastically increases, cholesterol level increases, and urine and fecal urobilinogen, that means the stercobilinogen and the urobilinogen is completely absent in complete obstruction, and bile pigment, that means bilirubin, bile pigment is present in urine, and also bile salt is present. hepatic jaundice, and the urinary changes. We already discussed. Bilirubin, bile pigment increases, urobilinogen is produced in incomplete obstruction, and in complete obstruction, urobilinogen is completely absent. And also fecal changes, stercobilinogen, produced in incomplete obstruction, or fecal changes such as stercobilinogen is completely absent in complete obstruction. Pathogenesis of hepatic jaundice. There is impaired or absent hepatic conjugation of bilirubin. Impaired or absent hepatic conjugation of bilirubin. Familiar or hereditary disorders, then acquired disorders. Impaired or absent hepatic conjugation of bilirubin, we already discussed in our last classes, and Gilbert syndrome and Crigler-Najjar syndrome. In Gilbert syndrome, it's a decreased glucuronide transferase enzyme, and in Crigler-Najjar syndrome, it's a hereditary absence or deficiency of UDP glucuronide transferase enzyme. Familiar or hereditary disorders such as Lewin-Johnson syndrome and Rotor syndrome. Rotor syndrome is an inherited disorder characterized by elevated bilirubin in blood. Both Lewin-Johnson syndrome and Rotor syndrome increase the conjugated bilirubin level in blood. Then other reason is acquired disorders such as hepatocellular necrosis and intrahepatic cholestasis, for example, hepatitis, cirrhosis, or drug-related reasons that cause hepatic jaundice. Hepatic jaundice symptoms: weakness, loss of appetite, hepatomegaly, palmar erythema, and stridor. The weakness, loss of appetite, then hepatomegaly, that means enlarged liver cells. Then lab findings: liver function tests are abnormal. Liver function tests are abnormal. What are the liver function tests? LFT, bilirubin, total bilirubin, direct bilirubin, then AST, aspartate transaminase, alanine transaminase, alkaline phosphatase, gamma glutamate transferase, albumin, globulin, albumin-globulin ratio. Etc. are the liver function tests. Liver function tests are abnormal, then both conjugated and unconjugated bilirubin increases. Both conjugated and unconjugated bilirubin increases, and bilirubin urea increases. What do you mean by bilirubin urea? Bilirubin urea means the bilirubin or bile pigment present in urine. This bilirubin urea increases, and the urobilinogen is also present. Lab findings: liver function tests are abnormal, including bilirubin factors, enzymes, and the albumin, globulin, and AYG ratio. The liver enzymes are the aspartate transaminase, alanine transaminase, alkaline phosphatase, gamma glutamate transferase, and 5-nucleotidase. The liver function tests are abnormal. Then both the conjugated bilirubin and unconjugated bilirubin increases. Both fractions are increases because the hepatic cells contain unconjugated bilirubin and conjugated bilirubin. The unconjugated bilirubin in the hepatic cell, it is converted to conjugated bilirubin with the help of the enzyme glucuronide transferase enzyme, and otherwise it's the UDP glucuronide transferase enzyme. So the conjugated bilirubin and unconjugated bilirubin level increases in blood in case of hepatic jaundice, and also bilirubin urea. It means the bile pigment bilirubin is present in urine, and also urobilinogen is present. the laboratory findings of the hepatic jaundice we already discussed. The serum bilirubin level. Total in hepatic jaundice, total bilirubin increases. That means both the conjugated and unconjugated bilirubin level increases, and the AST, aspartate transaminase, highly increases. This is a aspartate transaminase, and aspartate transaminase is a liver specific enzyme. AST increases. Then alkaline phosphatase increases, gamma-glutamyl transferase increases, albumin. Albumin is almost normal or slightly increases, then reticulocytosis. Reticulocytes percent is normal, and the prothrombin time. Prothrombin time, normal it is, prothrombin time is increases. Normal is 13 to 15, and prothrombin time increases up to 15 to 45 seconds. ALT is also increases. ALT is also increases in the hepatic jaundice. ALT, alanine transaminase, is also increases in hepatic jaundice. The hepatic jaundice, urinary changes. Bilirubin or bile pigment present in urine is normal or increased. Urobilinogen normal or reduced. Fecal changes, stercobilinogen or fecal urobilinogen normal or reduced.